Okay, so thank you everyone for joining us today. My name is Mark Driscoll, and I am the program manager with the Ohio AAP for the Preventative Health Program. Just a couple notes from me. If you are applying for CME or MOC Part 2 after today's presentation, I will send instructions on how to do that either after the presentation today or tomorrow, hopefully by the end of today. So you'll have everything there that you need in that email. Our presenters had nothing to disclose or no financial relationships with ineligible companies. And other than that, I'm going to go ahead and kick us off to Dr. Rich and Dr. Modi and let them start in. Thank you for speaking today.
Thank you for having us. We are excited to round out this third part of our adherence series and really hopefully get a little bit into the nitty-gritty on what you can do in a clinical setting and how we address barriers and get to behavior change in the work that you do. So I'm Avni Modi. I am a professor and division director of the Behavioral Medicine and Clinical Psychology division at Cincinnati Children's. And Dr. Rich is an associate professor who I've had the pleasure and privilege of working with for many, many years, especially in this space, and is also at Cincinnati Children's with me in the division. So our objectives today, not that you have forgotten what was covered last week, but just to do a quick refresher on adherence barriers and what they are so that the context of the work that we talk about today and interventions really translates into everyday practice. We want to give you some practical strategies, talk about what adherence interventions work and what we know from the literature, and then end with a case example. And then, of course, any questions or discussion that folks on this call will have. So just as a reminder, adherence barriers are vast and wide. They can range from very individual level barriers like forgetting to take medicine, not liking the taste, having difficulty swallowing, to systems level barriers like not being able to get the medicine, having insurance issues, to very personal barriers, sometimes for our teenage patients where they're embarrassed to take medicines in front of their peers or in public settings, all the way to more healthcare and medical issues like side effects. And so folks not wanting to take the medications because they are experiencing other things from taking that medication, like side effects. So why do we care about adherence barriers, and why have we spent 3 sessions hopefully getting you to the point where we are convincing you that it's important to care? What we know is that when we look at adherence barriers, they predict actual adherence behaviors. So if folks are experiencing an adherence barrier, it is very likely that they are having difficulty taking their medication. We also know that if we don't address these barriers, they tend to stay very stable over time without intervention. And the great news is that we can address a lot of these barriers via evidence-based interventions that can be instituted in clinical practice fairly easily for some of them. The literature is pretty clear that when we look at a meta-analysis of all the studies that have been done to improve adherence, there are 4 main types of strategies that are used fairly successfully, with educational strategies being the lowest, having the lowest effect size. And you can imagine that just teaching people what they need to do may not be enough to get them to change behavior, but it is a critical portion of what you need to do to engage in adherence behaviors. And so if you don't know what you're supposed to do, when you're supposed to take medicines, it's really hard to kind of get the regimen down and work on some of the behaviors to do that. Behavioral strategies that target things like getting feedback on your behavior, problem solving around what's making it hard to take medicines are quite effective. Technology-based solutions, which you can imagine in this day and age, can also be quite effective. And what I want to highlight here is that healthcare provider delivered interventions and things that we do at the systems level have a very large impact on adherence behaviors. And we have seen this over and over again in the literature. So the role that pediatricians play in this is really important and can really change the trajectory of how kids take their medicines for the long haul. We know that a lot of the interventions that we're going to talk about today focus on modifiable barriers to adherence, so things we can change. It is really hard to change if you can't get the medicine because your insurance company doesn't cover it. That's a very systems level barrier that we're not here to discuss those particular barriers. We are focusing on the things that we can change in practice for today. We know that it's not a one size fits all. The barrier that I might experience taking a medicine can look really, really different from what you might experience. And it may be very different from what my kids experience. And so it's really important to know that we have to understand what is making it difficult for that individual or that family. And there may be multiple things that we have to target. It may be that a child doesn't love the taste of the medicine and fights it. And so there might be two different strategies that we would use in those situations. And sometimes we want to try one strategy and then the next one. So really thinking about a stepwise fashion and how we would engage families. We may need to do this on an ongoing basis. And Dr. Rich and I are here to tell you you don't always need a psychologist to do behavioral strategies, though we don't want to go out of business. So if you would like to refer to us, we would be happy to take your patients too. So what are some of these educational strategies? I alluded to this a little bit earlier, but it is really important that we build the foundation around families and kids knowing why they're taking the medications that they do, what it's for. And sometimes that's not always clear to families. They may think an antibiotic is for one thing when it's for something totally different. And so I think, we sometimes take for granted what folks understand, and explicitly reviewing instructions on what medications are for and how they're supposed to be taken is really, really important, including what side effects to look out for. Because in everyday decision making, a person may stop taking medicines just because they don't like one of the side effects. And if you can at least guide the family in knowing what to look for and to contact you or your nurse so that those side effects can be addressed, can really go a long, long way. But like I said before, knowledge is necessary, but it's not sufficient to change adherence behaviors. Some of the behavioral strategies that we often use are just basic reminders. Can you set an alarm on your phone? Is there an app that you can use to remind yourself to take medicine, or if it's an adolescent, it reminds them? Are there ways that we can reinforce these behaviors, right? So if a child takes medicine, is there something that we can do afterwards? Do they get a special surprise if they do it for 2 days in a row? Do they, earn 15 minutes of TV for taking the medicine as we want them to? And the more we can do positive reinforcement around these behaviors, the longer term we are teaching kids that it's important to take medicines and do it consistently. We can also problem solve what's getting in the way. How do we address that particular barrier? And we're going to talk a little bit towards the end. Dr. Rich will cover some strategies that we use for particular barriers and how you problem solve around those strategies and tools that we've created to do that. How do we have feedback and monitor our behaviors, right? So I'm sure many of you in the room have an Apple Watch or a Fitbit, maybe not a Fitbit anymore, but back in the day when people had Fitbits, and we would use that data to tell us how many steps are we walking, how much water are we drinking, and those feedback loops can be really important. So even basic charts that families can create to look at how they've done for the past week, put a check mark down, those can be very, very effective for especially young kids. I'm sure motivational interviewing is not new to you, but understanding the rhythm and rhyme of why people engage in behaviors through motivational interviewing and change talk can be really important. Sometimes it's important to teach particular skills. I'm going to just share a personal anecdote. As somebody who's had asthma most of my life, when I was a teen, my physician asked me to show him how I took my inhaler. And lo and behold, I had been taking it wrong most of my life. So even just some of that review on how you make sure that the child or the teen has the skills to take the medication as prescribed, whether it's an inhaler or a shot or oral medicines, is really, really important. And then we put down here anxiety interventions. Sometimes, if people are fearful about taking medicine, the intervention can look a little bit different, right? So, how do we address those fears and concerns that folks might have? As I mentioned before, healthcare system strategies are critical to success. There is a lot that we do at the healthcare system level that can affect adherence behaviors. And targeting and making sure that families have accessibility to those is really, really important. Talking about adherence, as you might have learned in the last couple sessions, is really important. How do we normalize these conversations? How do we make it okay for people to share that it's difficult taking medications on a daily basis, so that there's things that get in the way? Also, from a system standpoint, are there ways we can reduce the complexity of regimens? And that's not always going to be the case for something that's acute, but for chronic conditions, are there ways that we can make the regimen as easy as possible for the patient? I know many of you think about those things, but just as a quick reminder on that too. And then how can we adjust medications to make sure that side effects are not intolerable for the family or the patient? So I just wanted to review this one study, this one meta-analysis that was done. It was done actually almost 10 years ago, 12 years ago, but still shows that, in 35 randomized controlled studies with almost, 4,500 kids, that the healthcare delivered interventions produced really, really good effects immediately, and that even the longer term follow up on those interventions was actually quite robust with an effect size of 0.3. So, not only is what you do important, it also lasts for a while. All right, I'm going to turn it over to Dr. Rich.
So, building off of this, we've seen there's a lot of benefits and power in pediatricians, individuals that are seeing kids as part of their daily care or routine care, can have an impact. Um, One thing through all this research, we've figured out that there are strategies that can effectively address adherence barriers. But unfortunately, because of lots of system levels barriers, practical barriers, insurance barriers, very few clinical practices actually implement these interventions. So we are kind of putting you to task, putting you to charge to see if you can help bridge a gap that typically takes 17 years for something to get from RCT research status disseminated and implemented into clinical care. So, how practically might you integrate barriers assessment and intervention tools into your clinical practice? One of the kind of best ways to do this is to make it standard. Thinking about just as you would ask, are there any side effects to the medication that you're taking? Checking different vital signs. We would encourage you to talk about the adherence and the barriers. So, not making the assumption that an individual is doing the treatment exactly as you prescribed, but rather opening up that as a discussion point. And if they are having some trouble, helping to assess what's getting in the way. We would really encourage you to make this a point of open dialogue. Think, as you guys probably know, there's a lot of kind of pressure, I think, on families to kind of please the doctors, say that we're doing things correctly. Yes, we're doing exactly as you've told, but unfortunately, if they are saying that, but we're not seeing improved symptoms, this can create some clinical confusion on what to do next. So, part of a way to kind of mitigate this is to really normalize that adherence can be difficult. Let people know that, a lot of people struggle with this, and it's okay for you to talk to them about it. We also want to make sure that, again, at that basic level, they know what to do and make sure that we're not making assumptions on they know how to take this or deliver this particular medication to their child. And we also want to lean into the power of shared decision making. We're going to share with you some of the tools that we've developed here that will be available for you all to use in your clinical practice to help engage people better on this problem and really partner with them. And then, of course, there are going to be situations where no matter how much you have assessed for it, no matter how much you've asked about what's getting in the way, or you have given them tools, there may be adherence concerns that are really refractory to the interventions that you're doing, or you see that there is a significant mental health issue or executive functioning issue that is getting in the way of adherence. And at that point, that's where we'd empower you to refer on to mental health care to help with that piece. So this has been studied qualitatively, and we've gotten some information on what adolescents in particular value in their pediatric providers. As we know, adolescents can be at higher risk for adherence difficulties, so we really want to hone in on what will grab them, what will help them feel engaged with their doctors. So one of the most important things that adolescents tell us is that they want to be seen as a human, not just whatever medical or mental health condition that they're presenting with. So, leading in and talking about what are they interested in, what do they like to do, how do they spend their time, can help with connection on that level, and also get you some additional information about what their values might be, and that might help you figure out how to best support them in their day-to-day with their adherence. They also want their providers to be focused on them as opposed to their parents. They're building that autonomy, that independence, and so they really are craving that. They also want honesty, trust, and respect. They're often well aware of things that we think they're maybe not aware of. And so usually they want people to be kind of straight with them and not kind of work around an issue. And they also want to see that their provider is knowledgeable and an expert in their area. Parents, on the other hand, also have things that they're looking for in their pediatric providers. They really want to feel listened to. And I know in a busy clinical setting, making sure there's time for that is very challenging. But by validating their perspectives and expertise and experience, you can really let them know that you heard. So, for example, I hear you say that it's really hard to get John his inhaler every day. And that lets them know that you heard what they're saying, that it's hard, and that you recognize and acknowledge why that might be hard. They want to feel comforted when they bring up a fear or concern. And they also appreciate when you communicate directly with their children as well. So the way we talk about adherence really matters. So there may be families coming in that are kind of expecting maybe to get in trouble if they let their provider know that they didn't take the medication as well as consistently as they should have. And so they may be concerned or scared about that. So we want to make sure that there's not any kind of implied or overt criticism of them when they come in and they're sharing an adherence struggle with you. We also want you to be specific with them. We don't want to make generalizations about, say they're on a few different medications. We don't want to assume that the adherence problem is with all of them, for example. We really want to hone in on what treatment they're struggling with, and also letting them speak specifically to how often, because they may say they're having some trouble, For one family, this could mean missing all but one of the doses. And for other families, this could be meaning they only took one out of a week's worth of doses. So really honing in on questions to getting as much detail as possible will help you. Um, we want to also lean into asking them about how the medication's affecting their daily life and quality of life. And what's really important, as you'll notice with most of these questions, is that we're using MI-informed communication, which means we're asking things in an open-ended way. We're not asking closed questions that end in a yes or no. Why this is helpful is it keeps discussion going, and it also doesn't lead anyone to answer in a certain way. So by how do you feel about taking these pills will get you much more richer information than asking something about like, do you like taking these pills? We also want to have an engaged conversation around side effects. So asking them very specifically, have you experienced any side effects? What side effects have you experienced? To help them engage in a communication like this, they may feel like they just have to deal with it or suffer through it, but there may be things that you can do to change that experience and then reduce a barrier for them. And then also just directly helping to identify the problem. And this question can be what makes it difficult? If they're not able to say, you can also provide a list or start asking them about some of the barriers that you know of to see if any of those resonate. As I alluded to before, I think an important piece of this is to kind of break down the hierarchy and let them know that you want to partner with them. Again, there is a power differential here, and there can be a lot of pressure, shame, guilt, if a parent isn't able to help their teen, in particular, or their child with their medication. So we want to say, we're going to address this together. We're going to work with you. When you leave here today, this discussion doesn't end, and we're going to be checking in with you to see if these interventions help. And that goes a long way for parents to feel more relieved, a little bit more confident, and hopeful that this can be addressed. This is probably one of my favorite recommendations to make. As pediatricians, in particular, as doctors, as healers, there's a lot of advice that you're giving. People come to you because you're an expert. They want to know, what's this problem? How can I solve this? But when it comes to behavior change, an autonomy of the families is really important in engaging them in this discussion. We know that people are much more likely to follow through with solutions that they've helped generate on their own than being given a list of things that they can do. So this is where that shared decision making really comes in and can be helpful. Again, we often are focused, we as in the healthcare system are often focused on problems, things that go wrong, things that need to be fixed. When we're talking about behavior, it's really important to also hone in on what's going well or what's improving. People feel more motivated, people feel more reinforced when somebody recognizes that they're putting work in and they're trying. So when you see that they're putting solutions in, or maybe symptoms are under better control because the adherence is improving, just acknowledge that. Let them know that you recognize they've put in the work and that you're still here to help support them. So, as part of our work here at Cincinnati Children's, we have created a kind of diagram flow chart here to help our providers that are in clinical care in pediatric settings to figure out, okay, my family has said that this is a barrier for them. What am I going to do about it? So, for the top 5 most common barriers that we see, we have created these shared decision-making tools, which I'll share with you in a moment, that we would encourage providers to have at hand to pull out and start the conversation. With some of these other barriers that maybe not as straightforward, we're either encouraging a discussion with the healthcare provider and the family. If you have access to support in a social worker to address some of these social determinants of health issues, if you don't have that resource, that may be somebody else in your practice that can support that. And then if there are, like I said, more substantial, significant mental health or behavioral concerns, this may warrant a referral to a mental health care behavioral medicine provider, either at the outset or if you feel like your interventions are not making a significant difference. So I think I got alerted that there were some questions in the chat. Before we talk about toolkits and strategies, are there any that, and I can't, well, I guess I could pull them up. Are there any that we should address now?
No, thanks, Kristen. I just am always interested about how we can help practices implement strategies like this. So I was kind of putting that question in there about what tools we can use, and which you're going to be getting to,
Yeah.
that we can use to sort of make sure that people are themselves sort of doing good adherence practice. So I
Yeah.
think you're addressing exactly what my
Okay.
question was. I kind of put it in there just as a parking lot question, so I didn't forget to ask that.
Good. And there's other things too. So I think stepping back a little bit, one of the things is this can be new and different to try to talk about and probably wasn't a focus. Like you learned how to interview and, ask about like, are you nauseous? Do you have headaches? Things like that, but not so much these other questions. So just practicing getting your wording down, even with your colleagues or practicing at home with your family members can be helpful. Also, just practically as people are building new habits, it can be hard, especially in a busy, short clinical encounter, to remember to do this at first. So some of the teams that we work with have updated their note templates to ask them, remind them, prompt them about adherence. So just like you have other sections that you want to check in on, just to put that in so that it's at top of mind. Avni, do you have anything else to add on that front? Okay. So I recognize that this may be a bit blurry depending on what screen you're using right now, but this is an example of a tool that we generated through multiple iterations, taking our most common evidence-based practices and putting them into one place. This tool, along with the others, was developed with multidisciplinary input with our team here, as well as with our patient and family partners to make sure that it was uh, like reaching all of the needs, catching the needs of the providers and the families that would be receiving this information. Um, we have a lot of ideas in here, and when a provider is using this type of tool, it can be a little bit overwhelming. So, with this particular barrier, we kind of give them a choice at the beginning. We say, hey, what do you think might work best for you? Do you think it would be best to use kind of like some type of sign or reminder? Or do you think technology works for you best? Or do you like to kind of put it in your routine? And then if you can get them to kind of hone in on one of those, that can drill you into more of these specific strategies because it probably will be overwhelming. So we were trying to balance giving a lot of ideas in case some didn't work out, but also not giving too much information. So that's where you as a provider can help them kind of whittle this down and think about where they want to start.
And the only thing I'll add to what Kristen said there is, we also know people come from very different socioeconomic backgrounds. And so we're really mindful in all of these tools to think about low tech, high tech, so that this wasn't an expensive thing that folks needed to do. Like you don't have to have an app, but if you really like that and that works for you, then that is certainly something you could find. So the idea being that this would work for all patients and families.
Yes, thank you so much. Another common barrier challenge we get at is, these are kids. They may not have learned to swallow pills yet. And in fact, it's not uncommon for children to have difficulty learning to swallow pills, either because they're fearful, it's scary, they had a bad experience, or they're just don't really understand the concept of this yet. So in this tool, it's actually two-sided. On the front, as we see here, there are ways of making pill swallowing easier if they want to try to mask it in that way. Other individuals like just guidance on how to swallow pills in general. And what we use here is something called the candy method. And on the back of this flyer, there is step-by-step instructions for individuals for how they can learn to swallow pills using incrementally increasing size of candy. So sometimes the candy really hooks them, and they can practice in a gradual way, working from like a nerd or a sprinkle up to something like an M&M. Also important in these discussions is it's important for you or a pharmacist to let the family know if there are any like restrictions around a particular medication. So it can't be crushed and mixed in anything, or it can't be chilled, something like that, so that they're not interfering with the actual medication. Um, This is another helpful tool, particularly for kids that are still on liquid medication. They often complain it tastes bad. And as they get bigger, the volume gets larger. So we wanted to provide information for how to mask that taste to reduce that barrier, whether they're taking liquid medications or pills, with some specific ones for liquid medication too. So as you can see, there's a lot of ideas. It's kind of presenting a few to the family and seeing what grabs them, or if they can generate their own ideas too. And then our other kind of top barrier is about teenagers. In particular, sometimes this is true for kids too, but they acknowledge that some embarrassment, not wanting to feel different, not wanting their friends to know that they take medication or why they take medication. And so we kind of want to guide them first to validate that that's a real issue for them, that other teens feel that way, and to help them with next steps. So either we want to help them say, like, do you want to be able to talk to your friends about this so you can take it openly? Or would you prefer to talk about more discreet ways that you can take it? So we use that to help guide the conversation to what their preference is. And neither is good or bad. It's just whatever they prefer to do. So we do want to transition into a case example, but I thought this would be a good time to check in, see if there's other questions just about the content we shared before we talk through a relevant case.
And feel free if you have questions to unmute and ask your question, or just put them into the chat and I can ask them as well. And I believe we'll have an opportunity for questions at the end as well.
Yes. All right. Okay, so let me close this out. So I think it's a little useful to talk through a scenario that you might face in your practice, and how this might actually look in reality. I would ask for some participation, either dropping it through the chat or coming online or coming off mute and saying. So I want to talk about Alex. She's 14. She was in your office prior for symptoms of depression. You determined that that was the diagnosis, and you started her on fluoxetine. She's back in your office a month later. She and her mom report that the symptoms are not better and maybe are slightly worse. This is a scenario that I know I've heard personally, and I think have probably come up in practices, and there's several different ways this could go. What is something you should do first, or a first step to take in this scenario? You could ask Avni, but she already knows the answer.
Dr. Bowling said, how is medication taking going? Ask that question.
Excellent. I like that for two reasons. One is it's an open-ended question, and it's getting at the adherence. Because I think in some situations, a first reaction or first response could be to think that something is going wrong with this treatment or this dose. And the first decision is to say increase the dose or change the medication. But that is on the presumption of adherence. So I really like that answer. So after asking her the question of how is it going with medication taking, you find out that over this past month, she's missed about half of doses of the SSRI. Good information to have. What would be an excellent next step is to take a step back actually and use this as an opportunity to thank her and recognize her for her honesty, and also validate that you know of other teens that have a hard time taking their medication. She's not alone. And this is what you're here to help her with. So I know we are quick to jump into the fixing and problem solving, but we want to reinforce that she was brave enough to talk to us about her adherence issues and validate her struggles. And then your next step would be to go in and assess the barriers. This is the point of saying, okay, what's getting in the way? What's making it hard? And seeing if she can give you some information. So because you're a thorough clinician, you asked about the barriers, and she lets you know that she forgets and just does not feel like taking it some nights. What might be a next step from here?
In
We
the
have a
chat, ask about
Okay.
reminders, apps, tools.
Okay, excellent. So this could be a point to ask her if she has tried any of these interventions before, for sure. Thank you, Donna. So in this case, again, being thoughtful that you have limited time and she's reporting multiple barriers here, I don't want you all to feel like you have to solve all the barriers in this one initial visit. Really, the important thing is that you've gotten this information and you've reinforced for her that you hear her and you understand what she's going through. So to lean into her teenage developmental stage in autonomy, you can ask her, okay, which barrier would she like to address today? What's most important to her? She, thankfully, the easier one, picks the barrier of forgetting. Again, this is a good time to normalize that a lot of teens have trouble remembering, especially something new that they haven't had to do before. And also the fact that she is dealing with depression, and that in and of itself can make adherence harder. And then at this point, you want to kind of move on to, again, use your motivational interviewing strategies to discuss intervention options. This could be working through the tool that you will have at hand, or asking her, what has she heard of? What has she thought of trying? Or would she like you to suggest some ideas that have worked for other teens? So there's a lot of different ways you could take the conversation, but the idea is that you're getting at, okay, what can we do to address this problem of forgetting? As you've talked with her, you find out that she usually has her phone with her, and her mom's at work, but her grandmother is home every evening. So this is really valuable information because it clues you into things that might support her and also that might not support her. So at this stage, it would probably not be helpful to suggest, okay, your mom should remind you, mom's here in the office, mom should remind you every evening. Mom isn't there, she's at work. So that's likely not to be helpful. So at this point, you see that she has her phone and grandmother's home. So these are two potential points that you can go off of to suggest by saying, there's a couple of things that might work for you. One is to use like a reminder app or alarm on your phone, or the other is to maybe see if your grandmother can help you out. Which of these would you like to do? At this point, she can either say none or she can pick one. If she picks one, then at this point, we want to keep stepping further. So as you can see, there's a lot of stages to this. We don't want to stop just at selecting a barrier because from the time that she leaves the office, there's a lot of things that will have to happen for her to execute this. And we want to help families think through this. So what you're going to try to do is help Alex and her mom plan out next steps for implementing that intervention. So say Alex says that she wants to set a alarm on her phone. Say, okay, when are you guys going to do this? When's a good time? Is your phone always going to be charged? What happens? What's a backup if your phone is dead? Those kinds of things. So just helping them anticipate, and that's going to help them be more successful of following through. And then we also just don't want to leave it here. We want you to say that a staff member is going to check in with them by phone or by portal message in a couple of weeks to see how it's going. That's not always likely that one, they were able to remember to implement the strategy at home, or the strategy they picked wasn't successful and they might not have next steps. So by the staff member checking in, you can see how it's going and pivot if needed. One of the things that people may be having reactions to is, oh my gosh, this feels like it takes a lot of time. And that is true. It does take more time than not addressing it. I think there's several counters to this that we often challenge people with. For example, there may be things that can be deprioritized in this visit because it's most important. And we also think about time and resources saved by having these discussions up front rather than changing your clinical decision making, increasing dose that could be harmful for her if she does start taking the medication later. And this is worthwhile. So we try to challenge that a little bit, knowing that time is a precious resource. So that's the content that we had to get through. Wanted to see what other questions people have or scenarios they've struggled with on this, or maybe anticipate trying to do this in their own practice.
And again, if you have questions, you're welcome to pop them in the chat or unmute as well.
Kristen, you sort of mentioned, like have not trying to address everything at once. And your strategy of like coming back was good. Are there what other strategies do you have when you find that there are multiple? I guess I'm asking this as an obesity care provider
Yeah.
because it's not just one thing. There's always this huge,
Mhm.
you know, array of challenges. How do you prioritize that? How do you manage multiple things at once? What are
Yeah.
some strategies?
Yeah, that's a good question. I'll say what I say and then let's see what Avni thinks too. So yeah, very fair point. So in my case, I would think about focusing on barriers that the family most realistically has control over, because they're most likely to be successful in that way. So again, thinking about with the modifiable things, is it that forgetting is the most like reasonable for them to address versus the child's really embarrassed, and that's going to take some more kind of time and discussions. The other thing that I would say in a situation like that is if you are seeing multiple barriers, that's probably a sign that they may need to work with a behavioral health specialist, because there are many layers to that, probably needing to be worked through, and just more support than you can offer in, monthly pediatrician follow-ups.
Some of those structural barriers too always worry about me too. Like, and so a lot of our providers are out in rural settings. Um,
Yep.
I know it can be a real challenge out there also. Have you had any thoughts or experiences for people in sort of under-resourced settings like that?
I
I'm
think
throwing
this
all
is,
sorts of challenges at you.
Yeah.
yeah, I mean, that it's tough, right? Like, depending on the resources that folks have, which is not always very many, one of the reasons we reviewed some of the tools that we did today is because you can use them in your practice and it doesn't always have to be you. It can be a nurse, it can be anybody in your team that could help support that work. Um, I think, the silver lining on COVID is telehealth, probably, right? And so there is more available in behavioral supports via telehealth, especially for folks in rural communities. And so that's important to sort of know that those supports do exist. And now people have access to them in a very different way than they did pre-COVID. I think, psychology was always advocating for telehealth, and COVID just pushed us into being able to have that access for patients and families, because we know it's also hard to come in, right? Like and adherence isn't an issue that by virtue people necessarily want to work on, right? It is a little bit of oh, I'm in trouble for this and I don't know if this is important. And so I think if we can blend it into clinical care in a way that just feels like natural conversation, it tends to go a lot further than saying like, you need a referral for X, Y, and Z. But getting back to Chris, like your priority areas, I also often, when I use these strategies with patients, I try to think where somebody can have early success so that it's helpful to them, right? Like we know that if we are working on forgetting or pill swallowing is one where patients and families are so happy when they get it. And it's a game changer. It's a life changer for travel and all kinds of things, right? So where can you get early success so that then when you work on the next barrier that's a little bit harder, you're building off of positive things that have happened for that family. So those are different ways to think about it. I wish we had a clean answer for you, but you guys know families better than anyone else. And so where you think you can get some easy early wins, I think is really, really important.
Those are great suggestions. You really opened my eyes to this, Avni, that like this is totally in the wheelhouse for most psychologists. Like if you, as a provider, if I refer to most psychologists and say, hey, I've got issues around adherence, I think a lot of times pediatricians forget
Yeah.
that psychologists you guys are really, really good at that. I just think we forget that sometimes.
And we have the time, right? 45 minutes is a long time to work on adherence once a week
Yeah.
for a few weeks versus 15
Yep.
minutes in the office.
Yep.
And I think too, just building off of the um, individuals who are serving families living in rural areas. Also thinking creatively about other maybe access points they have. So I know school nurses are also a limited resource, but if, for example, there's a school nurse that the child has access to, that may be somebody you can partner with for those more frequent check-ins, or maybe the school nurse can be the one reinforcing the child for the adherence. So just other partners that may not be as like that you might not think of outside of the parent and the physician.
There aren't a plethora of them, but there are sometimes some parenting nonprofits have people who can do it as well. We found that.
Yeah. Yep. So any engaged, adult that is willing to kind of help in this way is useful.
Well, we hope we ended the three-part series with some practical tools that you can use in your settings. So I think we've made them all available. Is that right, Mark? Or you guys are going to put together something?
Yes, yeah. So after I get the recording from today's, they will all be on our preventive health website, which I'll include in the email that I send tomorrow. But if there's no other questions, and if you have them, feel free to put them in the chat now. But I can kind of close us out and say thank you to our speakers, Dr. Rich and Dr. Modi. We also want to thank our sponsors at the Department of Health. Again, like Dr. Modi mentioned, I will send an email tomorrow with the link to all of the series. And then also a link for how to apply for your CME and MOC Part 2. As a kind of helpful hint, we mentioned a lot of motivational interviewing in this series as well, and we did a series earlier in the year on motivational interviewing, so you can find that on our preventative health page as well. Other than that, I hope everyone has a great rest of their day, and we will see you for our next webinar. Thank you. And Dr. Modi and Dr. Rich, are you willing to stay on for a little bit?